Okay, so we are going to start, like I mentioned in the email message that went out just a little bit ago. We have a few partner organizations joining us for today's call. So we're going to go ahead and start by sharing that. Each partner will share just kind of a brief introduction of their organization, the work they do, and how their work has shifted due to COVID. And then after they share their brief introductions, we will go ahead and move into discussion. And just as a note, I did share a link to a Google Drive folder that has some attachments in it. If you are unable to access those different documents, you can feel free to email me after this call, and I'm happy to get those sent out. But we will go ahead and start with Dr. Sarah Roberts from Advancing New Standards in Reproductive Health. Sarah, I'll go ahead and turn it over to you.
Thank you so much, Regan, and thank you so much for including me in this. I'm really excited to be here today and to hear and learn from your experiences as well. So I work for an organization called ANSWER, which stands for Advancing New Standards in Reproductive Health. We are a research group at the University of California, San Francisco, and we are an interdisciplinary, multidisciplinary group of investigators and staff. And our mission is to conduct innovative, rigorous, multidisciplinary research on complex issues related to people's sexual and reproductive lives. Our work is informed by an understanding of the role that structural inequities play in shaping health, and we believe in the importance of research in advancing evidence-based policy, practice, and public discourse to improve reproductive well-being. In terms of what I in particular do, I study the ways that policies in our healthcare system punish rather than support structurally vulnerable pregnant women. So I study both people seeking abortion and people who use alcohol and drugs during pregnancy. I would say in general, most of my work has just shifted to being from home and also shifted to a virtual format. I will briefly tell you about a virtual convening that we recently had about public health approaches to abortion, and also tell you a little bit about some of the rapid response research that we've been doing about COVID-19 and abortion. So for the past 5 to 7 years, I've been working on a project to really envision a 21st century public health approach to abortion that uses accepted public health values and frameworks to guide the work that public health professionals and health departments do about abortion. One of the handouts that you'll get at the end of this meeting is a vision piece we published a few years ago about that work, throwing some ideas out there. And then also another piece about experiences of maternal child health and family planning professionals in health departments doing work on abortion. We hosted a virtual convening now about a month ago that included many CityMatCH staff and many CityMatCH members to take that work a step further and really define a path forward for maternal child health professionals and health departments to engage with abortion. I've been working on 2 rapid response studies about the impact of COVID-19 on abortion providers and on abortion patients. The first study, we actually have some findings for, so I'll briefly tell you about it. We conducted a rapid response study with more than 100 independent abortion providers, so independent abortion clinics in all regions of the country. And what we found was that these clinics have been affected by the pandemic itself in terms of having staff and clinicians be sick with COVID-19 or symptoms of possible COVID-19. The legitimate public health response that's led to school closures, that has led to travel restrictions, that's led to the need for changed protocols and challenges getting supplies. And then in some regions, the targeted and politicized responses. The place where we see the most differences by region are in the targeted and politicized responses that have designated abortion as a non-essential service. And we see more reductions in services, abortion services, and more temporary clinic closures in those states. When I think a little bit broadly about thinking about a public health role in relation to abortion and the pandemic, I do think that abortion clinics in the short term are facing a number of struggles related to their financial sustainability and their workforce. And so thinking broadly about the role of public health, knowing that many people have constraints on what they can do when they work for government public health, clinics really need financial support, as well as support regarding hiring and rehiring a workforce and caring for the emotional health of their workforce. So similar to what we see about other healthcare providers, especially primary health providers, these pieces are necessary for abortion clinics as well. And then in the longer term, the findings really point to the need for public health pandemic planning and response to anticipate and provide for the needs of abortion clinics and thus the people seeking abortions. The last thing I'll say is that we've been doing another rapid response study. I've been doing work in Louisiana now since 2013, and we have been collecting data on the number of abortions in Louisiana now for a few years. And we, as soon as the pandemic started, we also adopted a practice of making mystery calls to the abortion clinics in Louisiana and neighboring states, so that we would be able to document the changes in service availability in Louisiana and the surrounding states for the duration, or at least the short-term duration of the pandemic, so that we will hopefully eventually be able to document the impact of different state responses to abortion during the pandemic on the number of abortions, number of births, as well as adverse maternal and newborn outcomes. So with that, I will finish, and I'm really looking forward to hearing from you. And please feel free to get in touch with me by email or to follow me or answer on Twitter. Thank you.
Thank you so much, Sarah. We are going to now move right along. We're going to turn it over to Jenny from NIRH, the National Institute for Reproductive Health. And Jenny, we'll go ahead and turn it over to you.
Hi, everyone. Thank you so much for having me. I'm really excited to be talking to you all today. Sorry that my slides are a little distorted. I can never know if it's going to be the more narrow or more wide slide format. So just to share quickly about the National Institute for Reproductive Health, we're based in New York City, and we work on a range of issues related to creating a society in which everyone has the ability to control their reproductive and sexual lives. We have a focus on access to abortion and contraception, but we work on issues much broader than that as well. We have several ways that we do the work, but our central strategy is to partner with organizations on the local and state level to support policies that they think are most suited to what their community needs. We provide funding and technical assistance and really become partners in whatever project it is that we're working on. And on the map, you can see that we are, all of the blue states are states that we're working in this year. And we also do create resources for the field based on our learnings that we luckily get to have from working with so many different organizations. So I particularly wanted to point you all to our local Reproductive Freedom Index. The model city graphic there is included in the Google Drive that Regan referred to. It evaluates 50 cities and counties on 37 different indicators related to reproductive freedom, and also provides a vision for how a city can fully live up to its abilities to offer reproductive freedom. It was developed before the pandemic, but I think it will hopefully still be useful. We also do our own advocacy in New York City and New York State where we're based. One of our values is really to create shared learnings and build interconnectedness in the reproductive health rights and justice movements. We do that in a few different ways normally, but during the pandemic, we've begun convening bi-weekly calls with all of our partners who have the capacity to join to talk about how the pandemic has been impacting their work. And so the recommendations on the next slide really come from what we've been hearing from them. And each of these bullet points could be, its own presentation. So I'm just going to name them quickly, and then as we talk, I'm happy to answer questions. I wanted to particularly point out that the protesters who often gather outside of abortion clinics did not change their behavior for the most part during the pandemic, continue to gather in groups. We didn't see that there was consistent mask wearing. And that really poses, beyond the public safety threat that it always poses, it now really has posed a public health threat to patients who are forced to walk through a crowd in order to access time-sensitive reproductive health care. So working with your community to enforce emergency orders or shelter-in-place or social distancing orders is one way that we think that it's an important response to the crisis of this pandemic. Anti-abortion pregnancy centers, or you may know them as crisis pregnancy centers, are clinics that are centers that really their goal is to seek to dissuade people from choosing abortion. They provide limited information that it's often coercive and stigmatizing. They do also provide, at some of them, free diapers, formula, baby clothes, although you may need to go through their programming in order to access it. And one thing that we want people to think about is during this financial crisis, folks who may not want to have to go through stigmatizing counseling or coercive counseling like that may feel that they have no other choice but to go to a place like an anti-abortion pregnancy center to access these free resources. So departments of health can do a great service by pointing people to other places where they might be able to access diapers or formula or baby clothes or pregnancy tests if those exist in your community. You can also work with local law enforcement, particularly district attorneys, to ensure that folks who may be forced to self-manage their abortion because they're unable to travel or because the clinics in their area may be closed, either due to emergency orders, which don't make exemptions for clinics, or as Sarah mentioned, just clinics needing to close for logistical reasons. Unfortunately, some people may need to self-manage their abortion, but this should be treated as a health matter. And you can really educate district attorneys on that. I know that budgets are tight and also very complex right now, and that cities are really focused on funding the basic needs for their residents. But I do want to suggest that you think about using some of your budget to help people access abortion care. In most states, Medicaid does not cover abortion. Many people have lost their insurance and so no longer have insurance coverage, even if they did have abortion coverage previously. And of course, money's tight. So I would say that for someone who's pregnant and doesn't want to be, that access to abortion is a basic need, and helping them access that care is an important use of local funds. There's also a lot of confusion about what types of healthcare that you can access during shelter-in-place orders. Things are opening up again, so it may become more clear, but if we see shutdowns again, I think that people are wondering, where can I go to get an STI test or contraception? Is that happening right now? Are the abortion clinics in my state open still? So providing that information to folks and making sure they know where they can get the care that they need and what's still open is really important. K through 12 sexuality education is always incredibly important. We think that this pandemic, like when we think about K through 12 education, that also includes things about hygiene. Like a lot of people had to learn how to wash their hands for the first time, which does come up in K through 12 sex education. I also was reading an article just before this about the ways that you can incorporate racial justice into a sex education curriculum, which I think is more important than ever now. And of course, I also just want to mention access to STI treatment and contraception is still important in this moment. Two programs that I think are great are expedited partner therapy and condom by mail programs. New York City just expanded ours. I'm sure that there's others that I'll learn about from you all, but those seem really well suited to this moment. So I'm happy to talk more about any of that, but I'm also really interested in what you all are working on. Thank you.
Perfect. Thank you so much, Jenny, for giving us that presentation. And as I noted before, both of those presenters sent some attachments. Those are included in the Google Drive. If you're not able to access that, you can shoot me an email after, and I'm happy to get those sent over. I am going to turn it over to Denise now, who's going to lead our discussion portion of today's call.
Great. Thanks, Regan. Thanks, Sarah and Jenny. Now we really want to hear from you all. In the way that we've done this before, is we just really open up. We have some guided questions here to get the conversation started, but if there's something else related to this topic that you want to make sure that we cover, you are more than happy to bring that up. We can use chat too, but it's great if we can get some dialogue going on the call. So some of the questions that we have here, and we can start anywhere, are for those who or maybe are just on the phone and can't see the screen. What components of sexual and reproductive health have been most impacted in your community, thinking during this time of COVID-19? What disparities have maybe intensified, and how's your health department responding? We know, for those of us, probably everybody on this call, none of us are shocked by the disparities. We know they exist. We know the inequities that exist. But COVID brought it to a point where like other people were understanding it or asking about it or wondering, and there's been conversations. But we also know in responses, some of those inequities have just been intensified in some of the responses. So we'd love to hear about some of that. How has your health department been challenged when you're thinking about reproductive sexual health, and what has your health department had success? And then looking ahead, what impacts do you think will be long-lasting post-COVID-19? So that's a lot. There's a breadth of stuff there. So we'd love to open it up. Who would like to jump in on one of those questions or share challenges you're having, successes you're having? What's been most impacted in your community when you think about sexual and reproductive health? Floor is open. *6 to unmute.
Hi, I'll start. This is Claire Kirscher. I'm with Healthy Start in Escambia County, Florida. I think, so we are largely home visiting, and one of the largest impacts I think we've been seeing is changes in prenatal care for women. Either providers are changing appointment schedules to decrease their exposure in the offices, or women just aren't going in for visits. We've had a couple of clients who said they went in for their gender reveal visit and then haven't gone back unless something is wrong. So we're really concerned about how that might be affecting our birth outcomes. And also with home visiting, we've moved to completely virtual, which has its own barriers for clients who aren't able to access that, and all we can do is telephone. And that is actually, if it's a question I'd like to hear from others who are home visitors, are you planning on keeping a virtual option for patients or clients who might not want to do home visiting? Because I think we've definitely seen a lot of that hesitancy as well, even though they know it's virtual for now.
Thank you. Those are great examples, and I know you're not alone in these challenges, so we'd love to hear from others.
And it looks like we did have, this is Regan, a hand raised. Siobhan, did you have something you wanted to share?
Yeah, so I think there was a real attempt, I think, for adult women to make sure we work really closely with our primary, my name is Siobhan Nester. I'm with San Francisco Department of Public Health. And we had a very rapid and robust response to COVID, but that also resulted in at least half of our staff, both at MCAH, where I'm located, and in primary care, which oversees the community clinics that that our program works most closely with. Half of our staff were activated for the COVID response. So I think this move to telehealth has had a tremendous impact when we talk about disparities on people's access to these services, just because we moved to having pretty much all of the basic contraceptive services handled through telehealth whenever possible. We know that a lot of people in our community don't really have that sort of access. The other thing that happened was that youth access was severely curtailed. Most of the youth clinics were closed, and the one clinic that remained open was only able to offer telehealth services because the building in which they were located was closed. I do think that we had some successes in bringing together a large coalition of people to work on some of these issues and to expand access. But I am concerned especially about two things. Early on in the epidemic, we were only testing people for STDs. We stopped doing screening, and I think we're going to see a real increase of in STD rates among our youth. We already have some of the highest rates in the country. And I'm also concerned about this move to continuing with telehealth, because I do think that it really limits access to a lot of our population.
Thanks, Siobhan, and it's great to hear you. Thanks for sharing others, because you're right. I mean, you all are bringing up really great points. And I also just want to share, some of you might see, but we do have some folks from federal government and funders on the phone. So I think it's really great for them to hear what's happening on the ground as well, both successes and challenges and impacts and what we'll read about long term. So we can be thinking about strategies. Who else has got something?
Hi, this is Marni Nixon. I'm sorry I'm on the phone, so it's hard to see how to raise my hand on such a large call. But I just wanted to add to that is one thing that we're hearing. I'm right here on the U.S.-Mexico border in southern New Mexico, so about 45 miles west of El Paso, Texas. And related to telehealth and youth, we are hearing about STI rates going up, or young people who are tested not going back for results, and the difficulty it is in getting back to young people as the economic effects and fallout from C-19 are causing either their personal phones to be taken over by other adult family members, or just loss of those phones. So that has reduced their ability to access telehealth, for example, and to follow up with their care providers for confidential services.
Hi, this is Staci Davis from the Perinatal Health Equity Foundation in New Jersey. I'll share that for us, our organization is very centered on breastfeeding support. And so all of our groups had to move online, which, you know, is working, but it's not the best. And we've also been limited with our ability to provide inpatient services in the home. WIC had also been limited in their ability to provide breastfeeding support. So what we're finding is a lot of women are being discharged home from the hospital with formula. And so as a community serving Black women who already have disparities in breastfeeding, we're seeing our numbers begin to drop because formula supplementation is increasing, and then there aren't any resources for them to go to when they're struggling. And doing telehealth lactation consults comes with its own challenges. It really is a hands-on service. And so sometimes the inability to see things in person and do exams and assessments doesn't allow you to get people the right latch and get things going well. So I am personally very concerned about what our breastfeeding rates are going to look like after this, and how many women are taken off of their journey in success. But I was fortunate to be one of the recipients of our Department of Health pandemic grant. So we're hoping to be able to jump in and help some things there.
Great, thank you to the last couple. Thank you.
Hello, this is Hakima from Kansas City.
Hello.
Hi. So I did want to jump in behind that previous one because we're seeing kind of the same thing here in Kansas City with the breastfeeding, except I feel like we've had a little bit more success. So our staff, IBCLCs, did go to virtual visits, although we noticed a sharp uptick. We were having more virtual visits than we had previously had in-person visits in our free walk-in breastfeeding clinic. So we experienced an uptick in the virtual visits. So women clearly were having problems with breastfeeding, but they were accessing us more. And so according to our protocol, everybody gets a virtual visit first, and then if the staff IBCLC, and we have a lactation intern program for folks wanting to become IBCLCs. So if the lactation consultant and our intern saw them online and determined that they needed an in-person visit, then we scheduled that. Our building is closed, but our clinic, is a space unto itself. And we have safety protocols in place. We've stocked up on masks and gloves, so those are available in our space.
Let me send you a voice note because that's such a good idea and it's so much easier. So essentially the conversation was 15 minutes. She was very straight to the point. I had a whole list of things. We covered everything I wanted to talk
Is
about.
that someone on the call?
Yeah.
Sorry.
Sorry.
I guess that was someone who needed to mute. So they will determine if someone needs an in-person visit, and if they get it, then they follow our safety protocols. They have to be masked and gloved, wash their hands, take their temperature, all that stuff. And so it is possible to get an in-person visit. And then the other thing that we do is our Chocolate Milk Cafe, which is a Black family only breastfeeding support group that we created here at Uzazi. And we've actually seen an uptick in the attendance on that, even though it's all online. So we have a much greater attendance at our online meetings than we did when it was in person. So there's been an uptick in both of those, and we feel like we've been able to be fairly responsive. And being online, I actually, even though I went into it kicking and screaming just because I'm old school, I have to admit that it increases accessibility, and that women who are childbearing age, I'm postmenopausal now, so women who are childbearing age are much more used to that technology and are used to gathering that way. And so it doesn't appear to be as much as a barrier to me as to them as it appears to be to me. They actually access those services more. So that's been our experience, the uptick in the use of our walk-in breastfeeding clinic virtually and in person, and an uptick in the attendance at our Chocolate Milk Cafe.
Thank you. Who else has stuff to share? Concerns about impact, challenges, successes? Changes in your response?
It looks like Becky has her hand up. Becky, did you have something you wanted to share?
Yes, I'm with St. Louis County Department of Public Health in Missouri, and I manage a couple of home visiting programs. And I've been a little bit concerned about staff retention, because a few of the nurses have mentioned to me that they miss being out in the homes doing the home visits, and that the clients are still engaged, but the staff is not does not have as much job satisfaction as they did before when they were doing the home visit. We've also had to provide some phones to some of our clients that were not able to continue on with telehealth visits because they didn't have phones or Wi-Fi in their homes. And one of the things that we found that's been pretty successful is we partner with our local diaper bank, and after telehealth visits, the nurses will drive by and do porch drop-offs of diapers to kind of keep the clients engaged with us.
Thank you.
This is Tara at Denver Health Community Health Services, and I oversee family planning and reproductive health education. We are a Title X provider, and we also have a large program serving youth through school-based health centers. And I would echo the challenges reaching youth via phone have been very challenging. They text, they sometimes will call a hotline, but if we do try to call them back, they don't answer. I know their phones are often in shared spaces and there's family members at home. They don't have, a private confidential space to make some of these calls. So, we're looking into all options to be better prepared for the fall going forward. But as many of us know, some of the texting options to communicate for appointments and telehealth are costly. And we're also losing funding for different things right now. So just trying to be better prepared. We've offered Drive Up Depot. We've been proactively looking for young people and young adults who are due for refills and outreaching to them so we can do mail order refills if they don't want to come into the clinic, which is fine. So we've had a really great team be proactive in trying to reach all of our patients of reproductive age the best that we can, but it has been a challenge. Thank you.
Thank you.
I'm sorry, I was just wondering if I could ask a question as to what you've been finding with mail-in orders. We have discussed that, and part of the concern, especially for our youth under the age of 18, is confidentiality.
I don't have current feedback. I think, it's worked for some teams where the confidentiality piece is not the issue. We have had clinics where people can come by and pick up as well, but they would have to have a ride. So, it's really dependent on the patient and our health educators and providers, but we have offered, pickups in our parking lots and things like that, where they can just pop in and grab it if they already had the counseling over the phone. But it just really varies depending on the clinic. And yeah, we can't just proactively mail it to the home if we didn't have an okay from the young person.
Thank you.
I'm going to just touch on a couple things that are in the chat for those who aren't online. Someone to the California's Office of Family Planning says they've seen a significant decline in clients accessing their FamilyPact program. In Kalamazoo, the United Way and the Community Foundation are providing COVID-19 relief funds to buy tablets and prepaid phones for telehealth services. ACOG, they've been hearing from adolescent medicine providers that confidentiality with their patients is extremely difficult with sexual health services via telehealth. And then there's somebody's asking the question about if anybody's seeing trends with regard to LARC insertions and removals and how that's working. So respond to any of those or anything else that you want to talk about, challenges, share what you're doing, successes, worried about impact. I can see names. I know we have people here who have things to say.
Hi, this is Kamal here from Kalamazoo, YWCA Kalamazoo specifically. So some of the things that we've been seeing is we, along with some partners, have been hosting what we call COVID conversations, which are one-on-one interviews that we've been conducting via phone with community members who have recently had a baby or are currently pregnant to see what kind of challenges they are experiencing. And a lot of their healthcare concerns are regarding non-COVID healthcare. So for example, if someone is trying to get an IUD removed and they were told that they can't come in until August, and the concerns regarding that, the concerns regarding what will that do to their repro system, and the fact that the hospitals and clinics have their own protocol, but there's this lack of communication with the community about what that means for them, and just exactly how long do they need to wait. So those are some challenges that we've been having in clinics, as well as the conversations around decreased birth time, like that births are taking shorter, like a shorter amount of time to birth. And this is just kind of my own stance of what I'm seeing, is that clinics are more so saying that it could be because a lot of family members aren't allowed to come and visit, and now the mother can focus on the birth. But I wonder if some of that is also because like there's less intervention. Like it could go either way, and we don't know why that's happening. But we are seeing that births are taking shorter amount of time now. But mothers are feeling the lack of support because family members aren't allowed to attend, except for one family member, of course. But just that the whole scenario of right when you have a baby, something that's supposed to be a very exciting time is now even more stressful than usual.
Thank you. You touched on something that I know we've been hearing some about too, is concerns about mental health, maternal health, postpartum depression. So, you know, that's also if some folks have been doing anything around that or seeing anything or have plans.
This is Hakima again. I would just jump in quickly to say births are taking shorter because they're inducing every fucking body. And that should not be happening. It's throwing the C-section rate up higher than it's ever been, and it's gonna be a mess when this is over. They are doing inductions on everyone or pressuring them to do them. Those births aren't quicker by happenstance, it's by design. And this is one of the problems we're gonna be dealing with, is that hospitals have just gone whole hog on cavalierly trampling over the rights of childbearing people. And I'll mute myself again.
Thank you. We've been hearing that on various calls that, and we know that there are some guidelines that providers are following to minimize contact, but I think we all share concerns about the number of inductions and C-sections that are occurring at the rate they're occurring. And in some cases, you know, there's a lot there and a lot to be concerned about. Are others seeing some of the same things? Are you, I also am wondering, I heard today that some places are starting to allow more people present at the birth, while, you know, up until recently it's just been the one, and some have been able to have access virtually to perhaps their doula, but in some places we heard that wasn't even happening. But I'm hearing in some places it's opening up. So anything around that too?
Doula access is per hospital. Our hospitals are having different policies, which I think is making women change their birth hospitals, because some of them, one of them does allow doula as a considered registered medical professional, and then another is not, which ironically, the one that's not is considered to be the more natural friendly hospital in the area. So I think some women are changing their birth facilities to be able to have their doula available to them.
And again, I think we need to acknowledge the inequities there, because does everyone have the ability to switch their birthing hospital?
Absolutely.
So a lot of good stuff happening in chat, but I want to keep, because we can get to that. There's more to this conversation. I really appreciate you all being here and sharing. Because we want to make sure that we're lifting all this up so that we can be, you know, across the country, be working to make sure that we don't lose the ground that folks have worked so hard on around all of this.
Be able to figure out who else they've exposed. And it's the people that have been exposed to positive cases or presumptive cases that are the most.
Regan, does anybody have their hand up? Otherwise, I'm going to read some of the chat for people who aren't, because it's sounds like most it's still just one being allowed. Home birth rates are up. There's some comment about arbitrary NICU visitation policies. Parents being unable to see their children even when they test negative for COVID-19. Yes, we will. Somebody's asking if there'll be a summary of these comments. We will get those captured and sent out. Some are allowing doulas, but they have to be certified. Hakima, there's lots of comments about thanking you for speaking up. Some people hadn't seen data yet around C-section versus vaginal, so now they're going to be looking for that. I can also share that at CityMatCH, we will be reaching out to our membership. We do want to be trying to collect this data on all of this, on things that have been touched on this call, around workforce concerns and retention, around what we're seeing on reproductive and sexual health, what we're seeing with the inequities and responses, and if responses are improving, if any policies, because we do see some places where policies and procedures are changing for the better and to be more equitable, and then we've seen other places where they've doubled down. But we need to be able to, we're hearing the stories, and we really need to be able to collect the data so that we can be sharing that with our partners as funding decisions are made down the road. We want to make sure that we are lifting up voices that you all represent and what you're hearing. So what else? Somebody just put that in, some of the school nurses have put up Telehealth Hotline for pre-K through 12. They're doing weekly webinars. Oh, that's in Maui County. Oh, Jenny, Hawaii, right?
Yes. Hi, everyone. Yes.
I was like, it's probably the only place where there's a Maui County. Maybe, I don't know. I'm looking at who's all on this call, and I know there's others that we haven't heard from that have important things to share.
Hi, this is Kamal again from Kalamazoo. I just realized I forgot to share a important update. Is earlier this year we were working in collaboration with NIRH. Jenny is on this call, and we were looking into the needs, meeting the needs of reproductive health care in Kalamazoo. But a lot of that conversation died down when COVID began, because a lot of county level budgets and things of that sort were all in disarray. But now, since the conversation is at the forefront of disparities and inequitable access and just systemic racism and all sorts of systemic issues at play, we were able to revisit that and now got more solid commitment that we will be able to establish some sort of comprehensive reproductive health fund in Kalamazoo for women of color specifically to be able to tap into, whether that means fund for a prenatal or a pregnancy test, abortion, birth control methods, things of that sort. So it was stalled out for quite some time up until just a couple of days ago, and that's because the community has lit a match. So we're really excited about that in the near future.
That is exciting, thank you.
And there is a hand raised. Elena, did you have something you would like to share?
Yeah, sure. So, hi, my name is Elena Cavanaugh. I'm the training and data coordinator from the Northwest Ohio Pathways Hub. So normally with our clients for family planning, the two places that we're really seeing them being completed is at delivery and then at postpartum. Obviously with COVID, postpartums are being done either via phone call or webinar. Potentially some of our clients are being able to go in. But I was wondering, for the other programs that are working with home visitors, have you shifted your family planning education to placing importance at delivery? Because for us, it seems that if they're not getting at delivery, if we're waiting until postpartum, they're either not attending that postpartum visit or we are losing some clients at that point. So I was just kind of wondering if education has shifted.
Great question.
Hi, this is Rick Rodriguez. I'm from Kanda, Violence Prevention Services. And in one of the programs we have is working with middle school and high school students in terms of education on sexual health risks. And part of their curriculum is really following guidelines which must be implemented. And we cannot do this at this point because of fidelity reasons of the curriculum. But one of the pieces is reproductive health and anatomy that we revised. And since we're working remotely, it's kind of challenging to continue teaching education about reproductive health and visiting clinics as well for our youth and what's available. So I just wanted to share that because some of the schools we work with do have school nurses and health clinics within them. And so it's a challenge to even have students be referred there if they're not open.
Thank you.
Can you hear me?
Yes.
Okay, I'm Dr. Karen Chapman with the state of Florida. I'm the statewide family planning medical director, but I also run a county health department with a family planning program that's in a sort of a population of about 213,000 people, so we're not big. But we shifted to a lot of curbside services for family planning. So going out and giving depot or going out and giving their pills. We did still continue to provide some services in the facility. Oh, so like pregnancy testing, they really have to come in for pregnancy testing. So we continued to do that. And we made the choice that we didn't want to cut off access to LARC, either its removal or insertion. So we continued with, if a client expressed a desire to choose a LARC product, we gave her that opportunity to come in and have that inserted, or taken out. What we really didn't do was we really deferred PAPs. And obviously we deferred any copos that weren't absolutely necessary to be performed. We too also, when it was appropriate, converted our pill patients to mail order prescriptions, but we continue to serve teens as they were able to come up and get the pills. Teens in our community are not big on pills, so they were kind of used to coming every 3 months for depot, and they are more and more shifting to LARC. So what has been interesting for us, and I don't know about the rest of my colleagues in the state, but we did not take too much of a financial hit because of reducing our clinic schedule. I'm not exactly sure how they did it, but we were able to keep up a fairly good flow of clients doing the combination of curbside and limited interior in the building services. So that was a pleasant surprise because we were all worried about our inability to stay financially viable. Obviously, for something like my dental clinic, which is unrelated to family planning, but that clinic took a huge financial hit because they didn't have the flexibility of the types of services, given that so many of their services are aerosol generating. So that's just a brief experience of dealing with COVID from a family planning perspective in my part of the state.
Thank you.
Hi, this is Whitley Wynn. Oh, sorry.
Go ahead. Go ahead, Whitley.
This is Whitley Wynn from Indianapolis, Indiana. So we've been doing a few different things during this time of COVID. We've been focused on strengthening our partnerships with home visiting providers and hospitals who are, of course, still giving birth and working with families. So as those families are being discharged, we have been making sure that they are able to go home with the proper resources necessary to care for the infant. So specifically having that crib or pack and play at home for a safe space, and the sleep sacks, additional infant care resources for the families. It was really important for us to do that because our state Department of Health originally was providing funding around this program to provide cribs to various hospitals for this work. And this stopped way before COVID hit, and hospitals weren't really too concerned. And then once COVID really hit, there was a huge need for those resources to be available and to go home for families. Also with our home visitors, our partners really worked very diligently to find safe ways to continue to provide non-contact services for the families that they were currently engaged with. And they also received an influx of new families to provide home visiting to. So really over the past 3 months, we've given out almost like 100 cribs and infant resources to organizations working directly with families due to COVID. On the other end of things, we've really been concerned about the social determinants of health for the families here in Indiana and the implications of not being able to work, or being able to work and not having childcare, or the childcares that we specifically work with, since they are typically already lower income families, the fact that they had to close their doors, and how are they able to get their income? What does that impact look like? So our state was actually really supportive in being able to secure federal funding to provide ongoing grants for over these 3 months to childcares, so that they can continue to pay, whether they're staying open or not, to continue to pay their staff. And these were grants available to childcares outside of the PPP grants. And currently those grant cycles are still going on, but they are targeting childcares who are looking to open back up. As people are going back to work, we are finding that there is even more of a greater need and stressors on families to find support and to find a safe place to put their kiddos so that they can work. So just the understanding what stress does to the body and those implications on birth outcomes and whatnot are something that we've been concerned with. So we've developed a survey, and we have administered that survey to try to get feedback and responses from child cares and families about the current impact on their program, on their finances, and on their health and their social implications. Our state partners are very interested in this data, so we'll be sharing the data that we get back to our state partners for future planning.
Thank you, Whitney. We are at the top of the hour. I want to thank you all so much. We will get this recording out. We will get these notes out. really encourage you all to try to connect with each other. Regan and I can help you connect with folks, and to be aware if some of these things weren't on your radar, to maybe to be asking or checking on what's happening around things that maybe weren't on your radar. We appreciate you all being on. We care about you all. I would like anybody who's left, could we just like collectively take one really deep breath in and let it go? All right. Thank you all. Regan, anything you want to add?
No, I think it was a great call. Thanks everyone for joining. On the slide, you'll see contact information for myself and Denise. Like she mentioned, feel free to reach out if you have any questions. And then if you have any documents you want shared along with those already shared in the shared folder, you can feel free to send those my way.
Take care, everyone.
Thanks, everyone.